Thank you for the invitation to give this presentation on the current and future hemophilia treatments. Here you see my declarations of interest. On this slide, I show you the development of products to treat hemophilia over the last 50 to 70 years. Cryoprecipitate was introduced in the mid-1960s and the factor VIII and IX concentrates in the 1970s. As you all know, the problem with this was the viral infection. And this issue was eliminated in the mid-1980s with the introduction of viral activation methods. Recombinant factor VIII and IX products were introduced in the 1990s, and the extended half-life products were introduced around 2015. In the around 2018-19, emicizumab, the bispecific antibody, was introduced, and we now, as of 2022, have approved gene therapies for both hemophilia A and B. Here you see the hemophilia treatments, the current ones on the left and the future ones on the right. With the current products, we have the standard products, which are can be either plasma-derived or recombinant, and the extended half-life ones, which are obviously all recombinant. We have the bypassing agents and the bispecific antibody, emicizumab. In the future, we are going to have a further extended half-life factor VIII that I'll talk about, called BIV001 or IFA. We are going to have other bispecific antibodies. It's likely we're going to have very balancing therapies and also gene therapy. And I'll discuss all these treatments with you during this presentation. On this slide, you see the current treatment of hemophilia A. If we concentrate on the right, as you can see, mild hemophilia is treated either with desmopressin or DDVP or factor VIII, while severe hemophilia or moderate hemophilia is treated by the treatments on the left. If you have no inhibitor, you can be treated with factor VIII, either with standard or extended half-life products. And as you can see, there are a lot of these products available. There are 5 standard half-life recombinant factor VIIIs and 7 extended half-life recombinant factor VIIIs. You can be treated with emicizumab, and in patients with inhibitors, you can either have prophylaxis with emicizumab or FIBA, NOVO7, or 7-FACT. On this next slide, you see the treatments for hemophilia B that are not as numerous. We have the standard half-life factor IX products, and there are 3 recombinant and 18 plasma-derived products available. And we have 3 extended half-life products as shown on the right. Here you see the usage of these products in the UK over the last 20-25 years. On the left is factor VIII, on the right is factor IX. In the orange bars is the plasma-derived products, and as you can see, the usage goes down with time. Overall, the amount of products we use is going up and is mostly recombinant, as shown by the blue bars. The green bars are the extended half-life products. As you can see, they are more widely used for factor IX than for factor VIII. What is not shown on this figure is the use of emicizumab or Hemlibra, because that was introduced after 2019-20 in the UK. But currently, about half the patients with severe hemophilia A in the UK are using emicizumab. In terms of the replacement products, what is shown on this slide is the half-life of the products and the number of injections per week that you have to give for prophylaxis. For the standard half-life products, the half-life of factor VIII is 12 hours, and for factor IX is 18 hours. When you're giving them for prophylaxis, for factor VIII, you give them 3 times a week, for factor IX, twice a week. In terms of the extended half-life products, the extension for factor VIII is really rather moderate, and it goes to 18 hours, so you give them twice a week. But for factor IX, a significant extension at 90 hours, so you give it once a week. I'd like to next turn to the product that has been making the most change in the field over the last 3 years, and that is emicizumab, or Hemlibra. On the left, you see the function of factor VIII, which is to bring factor IXA and factor X together and initiate the coagulation cascade. When you have no factor VIII, these two factors do not come together, and you do not have activation of the coagulation cascade. On the right-hand side, you see what emicizumab does. Is a bispecific antibody with one arm of the antibody to factor X and one to IXA, and brings the two factors together and bypasses the need for factor VIII. So we have here the 4 key clinical trials that have been performed before the approval of emicizumab. Haven-1 was done in patients with inhibitors, in adults with inhibitors. Haven-2 was in children with inhibitors. Haven-3 was in adults and adolescents without inhibitors. And Haven-4 was giving the product once a month. You do not really need to know what these different trials are, because emicizumab can be given to children and adults, patients with or without inhibitors, and it can be given anything from once a week to once every 4 weeks subcutaneously. I will show you the summarized data of all of these 4 clinical trials together. And here is what you see. And on the y-axis is the mean annual bleed rate. And on the x-axis is the time you are or you have been on this product. As you can see, it's a highly effective treatment. And this is patients with or without inhibitors. In the first 6 months, the mean annual bleed rate was 1.9, and then it goes down with time. And even in patients who are giving it once a month. So on average, in these clinical trials, it was less than 1 bleed a year. Here you see some of the details of the drug. It's obviously used for patients with or without inhibitors. It's given subcutaneously, either once a week, once every 2 weeks, or once a month. It's increasingly used in children less than 1 year old. 75% of the patients are bleed-free, and standard clotting tests will be normal. So unless you're aware of how this product acts and you manage these patients, you can be misled. A person comes to hospital, has a blood test, a coagulation screen, and it's entirely normal. That doesn't mean they have a normal hemostasis. Essentially, emicizumab converts severe and moderate hemophilia patients to patients like mild hemophilia, but not to normal. And there are a number of other, at least 5 other bispecific antibodies like this in clinical trials. These are some real-world data that were presented in July 2022 at the ISTH meeting from the UK. It's a rather complicated table, but I'll take you through it in 2 different parts. Let's concentrate on the right-hand side, which is for patients over the age of 18. These are UK national data, and these are data collected after the product was approved. As you can see, in patients before switching to emicizumab, the annual bleed rate was 2.8, and the median after switching was 0. And importantly, the 0 bleeds, 29% before switch to 65% after switching. So all of these before switching, all of these patients would have been, or the majority would have been on prophylaxis with factor VIII concentrate. In children, it's even more impressive, and the median bleed rate is still 0, and 80% of the children have no bleeds. The next product on the horizon to treat hemophilia is a product called BIVV001 or efaneseptocog alpha, but people are now increasingly calling it EFA. And this is factor VIII that essentially has a true extended half-life. And it's better if I explain you why this is different by taking it to the right-hand side first. There is a product we talked about already that is an extended half-life factor VIII called Elocta. And basically, this is what the product on the right is. In blue is factor VIII, the normal factor VIII, and the way you extend the half-life is by adding this product called, is the FC part of immunoglobulin. So this is Elocta on the right-hand side. And what Sanofi has done to produce this product, essentially they're decoupling it from linked to von Willebrand factor by adding this D' D3 domain and adding additional products to extend the half-life. And importantly, during activation of the factor VIII, all of these other additional, the D' D3 and these X10 are cleaved, so you are left with the equivalent of Elocta. So in clinical practice, if you give 65 units per kilogram, it has a half-life of 44 hours. To understand what that means is that if you give a dose like that, after 5 days, you are going to have a factor VIII of about 40%. And even after 7 days, it will be 18%. In practice, what this means is that you can do surgery with a single dose, probably, or 2 doses of factor VIII, even in severe hemophilia. Last summer, we saw some data on this product, EFAM, in severe hemophilia in previously treated patients on prophylaxis. And whilst these patients were on what was considered to be good factor VIII prophylaxis, they still had a mean number of annual bleed rate of 2.96 and the median of 1.06. But when they went on to this product, the mean was 0.69 and the median was 0. So it's clearly a highly effective product and is likely to be introduced before too long. I'm now going to move to another group of therapies that are going to be introduced in the near future, and these are called the rebalancing agents. To understand this, I'll take you through the different parts of this figure. If you look to the top left in part A, normal hemostasis is the balance between the pro and anticoagulants. If you're missing some of the procoagulants, some of the blue balls, as in hemophilia, you tip the balance and you have more bleeding. Traditionally, the way we have been treating hemophilia is by adding blue balls to rebalance the cascade. However, it is possible to rebalance the cascade in another way by removing some of the red balls. And the rebalancing agents, basically, there are 3 products that are being developed and is by removing these red balls from the right-hand side. And these are the products that are in development. Fitusiran is an inhibitor of antithrombin. Concizumab and marstacimab are inhibitors of TFPI, their antibodies, and serpin-PC is an inhibitor of activated protein C. They would all work in hemophilia A and B. They're given by subcutaneous injection, and the aim is to prevent bleeds. They're not really geared to treating bleeds. The fitusiran and serpin-PC are given subcutaneously once a month. Concizumab is given subcutaneously daily. These products are in different levels of development, different stages of development. But I think the key issue about these rebalancing therapies was, can they be convincingly shown that they are free from thrombosis? Because you're rebalancing the coagulation cascade. To understand this issue, I'm showing you here some of the data on thrombosis in hemophilia. With factor VIII, the thrombotic risk is 1 per 1,000 patients per year. With emicizumab, there have been 30 cases so far reported. With fitusiran, there have been 5 cases in clinical trials. With anti-TFPI, 1 trial was stopped due to thrombosis that was being conducted by Bayer, and 1 was temporarily suspended due to thrombotic risk. That was the Novo trial. With the serpin-PC, there are too few patients have been treated so far to be sure, and in gene therapy trials, 2 cases of thrombosis have been reported so far. One of the most exciting developments in the treatment of hemophilia is gene therapy. And I will now take you through the recent developments in this. It's important to know what we mean by gene therapy when it relates to hemophilia at this stage. It's essentially gene addition. So an extra factor VIII or factor IX gene is delivered to the liver cells by a virus. What it is not is that it does not change the abnormal factor VIII or factor IX gene. It's not gene editing. So a person who currently has hemophilia gene therapy can still transmit hemophilia to his daughters. So this is what happens. Essentially, currently, all the gene therapies in hemophilia use adeno-associated virus, and the factor VIII or IX gene is inserted, and it's a single intravenous injection. On the right-hand side is Brian O'Mahony from Ireland having his gene therapy. This is an 1-hour infusion. Although the actual infusion of the gene therapy is in 1 hour, this is a very complex process because of the number of visits that the patient has to make. Here I try to show the pathway for the gene therapy for a patient. There are a lot of discussions before the decision is made to go ahead with gene therapy, and there is a final discussion and informed consent signing. After the gene therapy, patients have to have very frequent hospital visits because many patients can have an immune response against the virus, and that immune response can also destroy the production of factor VIII or factor IX. After the first few months, the number of visits are less frequent, and really the monitoring currently has to go up to 15 years. In terms of eligibility, we now have approved hemophilia A and B therapies. In Europe, hemophilia A is already approved Haemophilia B has been recommended for approval by the scientific body of the EMA and is likely to be approved over the next month or so. Currently, only approved in males with severe hemophilia and without current or past history of inhibitors. For hemophilia A, the patients have to have no antibodies to AAV5, but this exclusion does not apply for hemophilia B. They have to be over 18 with no active hepatitis B or C and no cirrhosis. Past history of hepatitis C or current HIV is not an exclusion, but if you have HIV, you have to have the HIV virus fully suppressed. These are the data from the approved hemophilia A gene therapy. And what you see is the mean factor VIII that, as you can see, by 6 months, it goes up to 40 to 50%, and then it slowly comes down. A big issue in hemophilia and gene therapy is the variability of the response in patients. By that, I mean you give the same dose of the gene therapy, but the patients have very different responses in terms of the factor VIII or factor IX that they achieve. Companies are very good at showing you the average factor VIII or factor IX. And this is good for research and for comparing products. But if you're a patient and you are considering having gene therapy, knowing what the average is not as useful for you as knowing what are the chances you will achieve a certain level. So if you're a patient, for example, you would want to know what are the chances you are going to have a factor VIII or IX level above 10%, and how long will it stay above this level. To understand this issue of variability, this is a slide that you probably have rarely seen in studies. This is the factor IX levels achieved in the gene therapy that's going to be approved with time. And for example, if you take week 26, as you can see there, the level you are going to achieve is anything between 0 and 100%. Very rarely are treatments associated with such variable benefit. And with hemophilia A is the same. Previously, when I showed you the hemophilia A data, I showed you the mean, and you saw those beautiful lines coming up and going down. Well, this is the reality. And as you can see, we go to 24 weeks again, and you can see the levels can be anything from 5 or 10% to over 200%. And with time, the levels come down. For patients, it's much more important to know what levels you'll achieve. And these are the approved hemophilia A gene therapy, and these are the 2-year results. So by 2 years, you're starting at 0, but by 2 years, as you can see, 14% will have less than 3%, 10% 3 to 5, and 35% 5 to 15. So as you can see, almost a quarter of the patients after gene therapy will have a level of less than 5% factor VIII. Another important aspect is the durability. How long will gene therapy last? For hemophilia A, it's believed to be around 8 years. For hemophilia B, it's probably in the 10 to 20 plus years. The levels do not appear to be coming down in the hemophilia B gene therapy trials, as you can see on the right-hand side. With gene therapy, there are some long-term issues that patients will need to consider before taking part. A key question is, how long will it last? Another issue is the safety, and in particular, the unknown unknowns. This is a new therapy that you have it and you cannot take it away. So what will happen in 10, 20, or 30 years' time? That's an issue patients will have to consider. And another important issue is, if you have gene therapy, does it increase your risk of cancer? This is a strange question to raise, but to understand it, I will discuss it on the next slide. Before doing so, I wanted to show you another issue, which is, although currently the gene therapies are getting levels of about 50% or less, sometimes the levels can go to very high. This is a patient from a publication in the New England Journal that had gene therapy for hemophilia B. And as you can see, his levels went to over 500%. And this patient did end up getting a thrombotic event and is now on long-term antithrombotic therapy. In terms of the cancer risk with gene therapy, AAV virus has been sold as a non-integrating virus, but that is not completely true because it integrates to a small degree. And because you're giving such huge amounts of virus to the patients, that integration is not really so negligible after all. So far, there have been around 300 patients with hemophilia who've had gene therapy. And as you can see here, there have been 4 malignancies reported. One was a liver cancer, one was a tonsil cancer, salivary gland cancer, and acute lymphoblastic leukemia. All of these have been judged to be unrelated, but really only time will tell us whether these therapies are associated with cancer risk or not. There is an issue because all of these cancers currently are investigated and judged by the companies that produce the products. Many of us feel that these should be done independently by a group that is unrelated to the company. Another issue is, how do you know if this is more than expected? That's going to be the biggest challenge going forward in this area, because once you go through and you give gene therapy to a larger number of people, there will be a background malignancy risk that you would expect. And deciding whether this is more or less than expected is going to be a challenge. Another issue is the cost. We now have indications of the cost of these therapies. For factor VIII, it's likely to be 1.5 million euro per dose. And for factor IX, because so far the approval has been in the United States first, is 3.5 million US dollars. The companies are really giving these prices based on US costs. And countries pay for their products in very different amounts. In the US, concentrates and Hemlibra are up to 10 times more expensive than they are in Europe. Will anybody in Europe pay 3.5 million US dollars for factor IX gene therapy? No way. I cannot see that happening. That price will have to come down in a major way before it can be considered. But there will be certain different models that will be used to pay for these products. For example, one way is the countries that have got a national healthcare system can say, we'll pay for hemophilia B gene therapy X amount for up to, say, 10 years, provided there is continued expression and the patients are not getting any joint bleeds. Gene therapy sounds very exciting, but it's important to appreciate there is competition. And in hemophilia A, with emicizumab, 70% of the patients are bleed-free. And the same with hemophilia B. If you use intravenous factor IX, 70% of the patients are bleed-free. So patients will have to make a big decision. Do they go from current treatments that we believe we know their side effect profile, and they are 70% bleed-free, to a novel therapy whose long-term safety profile is less clear? Gene therapy with AAV vectors cannot be used in children, and for them, lentiviruses are probably going to be the answer. These trials are starting in India. For persons with antibodies to the vector, there are clinical trials going on to see whether they can be overcome by giving bigger doses of the vector or trying to remove these antibodies. For patients with factor VIII inhibitors, again, clinical trials are starting. And the idea is, if you are producing a low dose of factor VIII all the time, could it be used like an equivalent of immune tolerance induction? And for patients with bleeding disorders other than hemophilia, I will discuss separately. There are a number of bleeding disorders that are much rarer than hemophilia, such as severe factor X, factor VII, factor V, factor II deficiency, or Glanzmann's thrombasthenia. I cannot see a company developing gene therapy for these extremely rare bleeding disorders, because for them it's not going to be profitable. The technology to do it is available even today, but it's just exploitation by commercial companies. The way I think this is going to plan out is that there will be a platform technology that will be approved. For example, AAV5 gene therapy platform will be approved, and then the different genes will be available as cassettes that are inserted to the AAV5 backbone that can be given to patients. And one possibility, I believe, is that these type of therapies will be given by university research labs or publicly funded labs. For example, if you're doing gene therapy in factor V, by the time you did your phase 1, phase 2 clinical trial, you probably would have treated most of the patients with severe factor V deficiency available in Europe. As we come to the end, I've got a slide about some of the other rarer disorders, and with currently available treatments in the future that is not gene therapy based. So in the middle column, you see the products that are available for these disorders, and on the right-hand side, you see the products that are being developed and are being tried. And as you can see, for example, in factor V deficiency, that's a true orphan disease because currently only fresh frozen plasma can be used. There is a factor V concentrate being developed by Kedrion in Italy, been under development for quite some time. So I wonder whether that's going to come to fruition. The rebalancing therapies that we discussed already can be used for factor VII and factor X deficiency. And there is an interesting bispecific antibody that is being developed for prophylaxis in patients with Glanzmann's thrombasthenia. As you can imagine, going forward is going to be quite a difficult challenge for patients because of this issue. How do you choose amongst all of those therapies? Obviously, efficacy and safety to some degree have to be shown by the time the product is approved. price and convenience is how do you put a value on those? Patients may put a certain value to those, but healthcare systems equally may put a different value. And I show you a picture from this book that is anybody who does business studies will know about, the paradox of choice. Essentially what this says, if you have no choice at all and there is only one treatment, you feel rather depressed. But as soon as you have a choice of another treatment, another 2 treatments, you feel very happy because you are able to choose what you're having. Once you go to having 10 or 20 treatments, however, you are not as happy as you were when you had only 2 or 3 treatments. And I think that's what's going to be, we're going to be facing in hemophilia. So this is the slide you've seen already. As I've said, we currently have good treatments for hemophilia, the standard and extended half-life, factor 8 and factor 9, the bypassing agents, the bispecific antibody, but the future is quite amazing. And we are going to have the extended half-life, factor 8, certainly within the next year or so. We're going to have other bispecific antibodies, the rebalancing therapies, and the gene therapies that have already been approved. If you wish to remain updated about developments in inherited bleeding disorders, and especially hemophilia, I am quite active on Twitter, and my Twitter handle is at the bottom, and you can follow me if you're using this social media platform. Thank you for listening. Goodbye.